Hi, so we're here today to talk a little bit about TTOs and the process for getting all of those drugs ready for people to get out of hospital. So I'm Dr. Sally Thrower. I'm one of the endocrine consultants, but I'm here with my specialties lead for clinical vision and flow hat on, and I'm with Carleigh Wright, one of our essential pharmacy team, and Kerry Morris, who's the lead sister in Discharge Lounge. So let's just chat. Hi.
Hello.
So Carleigh, bugbears about TTOs.
Yeah, I don't think we have particular bugbears, but there are definitely things that come down to pharmacy repeatedly that we could avoid, I think. There's some errors that we get in pharmacy for TTOs that we need to send back to the doctors, and that can cause delays in discharges. And very rarely is it actually clinical queries. So I think last year we did the early meds to release beds, and we got a lot of data from that. And about 8% of our TTOs that were returned to prescribers had clinical queries on them. The rest were things like the home medications had been pulled across instead of the inpatient medications, which happens a lot. Some medications weren't reconciled as well on the discharges. Some medications were incorrectly reconciled, or medications that were stopped were pulled onto the TTO by mistake. And I think it's just highlighting those issues to prescribers and to doctors that aren't necessarily aware that those cause a problem later down the line.
So by sort of clinical concerns, you mean that there's a question as to whether the prescription is appropriate for the patient because it's a drug interaction?
Yes.
So actually we're pretty good at getting those kind of things screened out.
At the point of discharge, clinically, the TTOs are normally pretty good. Occasionally there'll be scenarios where the dose is incorrect, or it needs to be reduced because of someone's renal function, or there's an interaction that wasn't picked up, or medications were started but now they've been stopped for an indication that they've decided wasn't there.
But we're perhaps not so good at making sure that the process on EPR has been followed correctly, and then that's causing us issues with the TTO going round and round in circles.
Exactly.
And that irritation of, can you modify this?
Exactly. And I think people forget the impact that has afterwards with primary care colleagues as well. So we get a lot of feedback from GPs who contact pharmacy, our medicines information department, with discharge summary queries. And a lot of the issues we get are when the patient's medications have changed their status. So on a medication, it'll say new, modified, pre-existing, and pulling over the home med on the TTO rather than the inpatient medication can disrupt that status. And then the GPs are confused as to whether it was stopped or whether it's new or whether a dose has changed.
Yeah, I get lots of those emails from a pharmacy tech in the community asking me about some patient that I've potentially never even met and what drugs were they meant to be on. And it does make a big difference to people when they go home. So it is important that we're accurate about those things, because trying to pick it out after the events can be really tricky.
Exactly, and it's hard to chase back what the patient was in for, were they under your care, what was the medication meant to be, because things are changed on a day-to-day basis, and then there's a lot of notes to scroll through. That can take a lot of time.
And I guess the thing is to try and not do the TTOs when you're rushed and thinking about 20 different things. They do actually need quite a bit of concentration, and you sort of need to be left uninterrupted.
Yeah.
If that ever happens on the ward.
I think that is another problem that you raised. So as I said, as we've said before, with the early meds to release beds, we only had about 43% of our TTOs down in pharmacy before 1 p.m. for the whole of last year when we look at the data for that. And that means over 50% are coming down in the afternoon, when we could be working in the morning on these, preparing the patients for discharge and letting them go a bit earlier in the daytime. But obviously you've got the hurdles of being in ward rounds and having to chase jobs before TTOs are written. So Sally, what do you think is one of the biggest hurdles of TTO writing? And how can it be fixed?
I think one of the problems is that the TTO can often be seen as that annoying job that needs to be done before someone gets home, that you get nagged about on the ward by people who are trying to get the patient's care moved on. You know, have you done that TTO yet? Have you done that TTO? And it isn't viewed as perhaps as an important task as it actually really is. If it's your gran, you want her to be able to go home. If it's your mum, you want her to be able to go home. And if we were better at pre-planning the TTOs and being more proactive about acknowledging, well, actually, this person may be going home tomorrow, we should write their TTO today, rather than leaving it to the last minute, it's more likely it will be done correctly because you're not doing it in such a rushed and hassled way. The whole team will be happier because no one's nagging you about it, frees up time for pharmacy because they're not doing it last minute, and ultimately it's better for the patient because that means that that patient can get home sooner, potentially.
Exactly, I'd agree with that. And I think from pharmacy's perspective, it is a mad rush at the end of the day. It's the same every day after 4 o'clock. Everyone's running around trying to get the TTOs done as quick as possible. And that then puts us at risk of making errors as well. And when there are things that we have to clarify with the doctors, it's then difficult to chase. And I think what needs to be done more is in the mornings when the pharmacists are on the wards, they could be utilised more to help facilitate discharges. Even if the TTO hasn't quite been written yet, let them know that you're planning on sending this patient home and they can at least order medication for them if they haven't already been ordered. And I think the pharmacists and the nurses are quite good at working together to make sure the patients are ready in terms of medication. So even if it does then take a bit longer for whatever reason because people get caught up,
And I think we need to challenge ourselves as well as the medical team to acknowledge that the TTO is actually an important thing that needs to be prioritised because that is part of patient care. It's not just the last thing to be done before someone goes home.
Yeah.
And it is good patient care for that patient, but also the patient coming on behind that can then use that bed, that then releases the person who can come up from AMU, that releases the person then to go from ED, that releases the ambulance to go and help somebody else.
Exactly. It's all about flow.
Yeah, it's all about, doing the right thing for patients and the best thing for patients.
And I can appreciate that some patients are in for such a long time, it's hard to write a summary, and whether we can find a way around that, maybe the summary can be started from the beginning in a way, and notes can be made or pulled through from the ward rounds that make it easier to write the summary. What do you think to that?
Yeah, I agree. In the old days of paper notes, you used to construct a regular problem list and that would be updated. And what tends to happen with the pull through of notes on EPR is that problem list no longer gets modified and corrected. So it's there on every ward round, that top list of, current problems. Actually, if you update that every day and add the tests that have happened or the scans that were negative, the important treatments you gave, and build that from the day of admission, you can then just cut and paste it into the TTO and your summary is done. And that's half of the job. I can't imagine how frustrating it is for the GPs when they see what is written sometimes, because they must be completely clueless as to what happened to that patient. And I know that when I get the queries back as the consultant with the GP saying what happened here, and I look at it and go, I've got no idea. I'm going to have to go all through the notes to find out.
And I think some junior doctors are sitting there going through all of the notes to write these TTOs, which then nobody wants to do that job because it seems like a long job. It's going to take you an hour to write a TTO, but like you say, if we can preempt that and solve the problem at the beginning where you've got the list of problems there and investigations and treatments, that make the job in the long run a lot easier. So it's trying to change that mindset, I think.
Yeah, and also I think as consultants, we all need to acknowledge that we need to give the juniors time to do the TTOs. And when we're doing our ward rounds, we need to release people to write the TTO once the decision for discharge has been made, if it's a same day decision, so that can be done straight away rather than it being a job that is left until the end of the ward round and after all the referrals have been done at 3 o'clock in the afternoon.
Exactly. And I think it will always be a job that takes 15, 20 minutes just to make sure it's correct. But when you've got people asking you questions and sorting out other things and you've got referrals going on the back of your mind to do, and it's easy to get distracted, but it can be quicker if you have that time to concentrate on it and have the resources you need to write a quick summary. So in terms of the nursing side of things as well, Kerry, do you find any hurdles with TTOs your end?
Yeah, we do one regularly. I think a lot of the issues that we do have at the moment is when we're in our OPAL frameworks and we have to take patients without discharge them in TTOs. But generally, we do find a lot of issues around patients coming down and then also the prescribing going back, the
return to prescriber.
which makes it difficult.
Yeah, and whenever pharmacy return a TTO to the prescriber, they always have to contact the prescriber.
Yeah.
And then when they return it, they put a comment in, which I'm not sure everyone knows that they can see, but if you go back into the inpatient discharge summary, you can see the comment, and it'll say, oh, please review frutamide dose, or please reconcile this medication, because we're having to look at TTOs where we don't know the patients as well, because we see TTOs from all over the hospital in the dispensary, and we can't make a decision on whether that medication should be stopped or carried on, because one, we're not prescribers, all of us, and two, we don't know the patient. So it is quite tricky, and we don't want it to seem like we're nagging the doctors or trying to bother you. We're just wanting to make sure we've got a complete TTO at the end of the service when the patient is discharged. So I think it is a view of working together. But yeah, so return to prescriber means that doctors need to review it, but they should already know why they need to review it.
But if we do have to take patients without discharge summaries, we're happy to screen the meds as soon as the discharge summary is done and send it to pharmacy.
And I think in discharge, and especially in a lot of other wards, the nurses are good at preempting medication and putting in supply requests, because really the only TTOs that should be coming down to pharmacy are the ones for compliance aids or for controlled drugs, because everything else can be ordered in advance. So all supply should be done earlier, and again that should speed up the process. But at the minute we're still seeing, yesterday we did 153 items, so you can see that we're doing more than just compliance aids and controlled drugs from that perspective as well. So yeah, I think nurses play a big part in the TTO process too.
Especially in the discharge lounge.
Okay, so I think we've done a good summary there of all the different tips and tricks on TTOs and some myth busting, and I hope we've helped a few colleagues out with how to optimise their TTO time and writing them to a good standard, and working again as a multidisciplinary team to make sure we optimise this patient care and again support our GP colleagues where possible too. Are you guys all happy with that?
Yeah, I'm happy.
Yeah.